Good evening, students. Can you all hear me?
Yes,
Just,
sir.
yeah, just react with thumbs up. Are you all audible? All right. So let's start from where we rushed during the last class, right? So we'll start with this clinical audit and ethics as well as this statistics, followed by perioperative care, right? Yeah. I'm going to re-explain all the clinical audit and service evaluation. So I think some 5 to 6 slides we have completed in this clinical audit and sections. So I'm going to take that class again. So let's start with the first question. Which is incorrect regarding the clinical audit and service evaluation? So it's nothing but a process used by clinicians who seek to improve care. Yeah, that is what a clinical audit is about. But before we answer this question, we'll just understand what is clinical audit. Audit is nothing but a process used by clinicians who seek to improve patient care by comparing the aspects of care against the defined standards. So there are the steps of audit cycle include you define an audit question like I'm going to evaluate the post-operative outcome compared to the post-operative outcome in a well-defined center. Likewise, identify the evidence and the current standards. You design an audit to measure the performance against the agreed standards, measured over an agreed period of time. Then analyze the results, compare your performance with the agreed standards. Then you undertake the gap analysis and finally you re-audit. This is how a clinician will audit themselves so that to improve their own patient care. So who seek to improve patient care? This is a true statement. In nothing but comparing the aspects of care against defined standards, that is also a true statement. It is designed to generate new knowledge by testing a new treatment or regimen. Generate new knowledge by testing a new treatment or regimen is the work of a randomized control trial, which is help identify the causal association. And majority of audits results in generating the hypothesis. That is a true statement. At the end of the study, like I'm using this suture material, so I have a less rate of incisional hernia. So that could be an hypothesis. Will this using the suture material against an already existing suture material has a reduced rate of incisional hernia? So that will be a hypothesis based on the audit. So this is a false statement. This is what a RCT will do. Now moving on to the types of scientific study. You have a quantitative study and a qualitative study. Quantitative study is nothing but it allows the hard facts to speak for themselves. Like quantitative study, it includes the patient surgical complication data or a mortality data or a survival or a progression-free survival or overall survival data. Whereas a qualitative study is nothing but it comes from the patient-reported narratives, like patient-reported outcome measures, like the quality of life studies assays. These are called qualitative studies. So overall, they are broadly classified into experimental and observational. In observational, you have a cohort study from cause to the effect, and then you have a case control study. You compare the selected cases with the matched controls. Then you have a cross-sectional study, and finally, case reports of studies. Moving on to the experimental study, you have a controlled trial and an uncontrolled trial. Among the controlled trial, you have further blinding in the form of randomized control trial versus non-randomized control trials. So this is the brief table that gives a brief definition of all the existing studies according to the Bayesian law. Observational study is nothing but an observational cohort study, which helps in evaluating the condition or a treatment in a defined population. That defined population is called as cohort. It can be either a retrospective study or a prospective study. So it starts from cause, you find the cause, then you reach up to the effect. So with this, you will be able to identify the relative risk. Moving on to case control study. Here, a series of patients with a particular disease or condition is compared with a matched control. All right. So this is nothing but you start from the effect, that is the disease to cause. Here you can calculate the odds ratio. Cross-sectional study is measurement on a single occasion, but not looking at the whole population, but selecting a small similar group and expanding the results. So it can tell us the prevalence of the particular disease, etc. Then you have the experimental study and randomized and non-randomized control trials you already discussed. If you look at the pyramid evidence-based hierarchy, number one, at the top will be the randomized control trial, which should be very well conducted. A very well conducted randomized control trial. That means that whether it is well conducted trial or not well conducted trial is where the validity of a study will come. Right. So we will understand that about the validity in the forthcoming slides. So at the top will be the randomized control trial. Just below to it will be below in the ladder will be cohort study, and you have a case control study. Then you have a series of case studies, reports, and finally only that expert opinion. So generally in any forum, if anyone is telling in my experience, that becomes the lowest level of evidence based on the evidence-based hierarchy. You have to not only eliminate the errors made to the chance or any bias, but also you have to eliminate and you have to find out whether it can be applied to the general population. There comes the internal validity and external validity of the study, which is very well possible with a randomized control trial. That is why it is kept at the top of the ladder. Then let's discuss this match the following. You match the study design. On the left, you have a study design, and on the right, you have the outcomes. So randomized control trial is designed to study what outcome. So randomized control trial is used to study causal association. Whereas cohort study, case control study, and cross-sectional study. Cross-sectional study, I have already discussed, it is to identify the prevalence. Cohort study, you start from a single, you start from the effect, right? You start from the cause, then you move to the effect. So you can identify multiple outcomes. So cohort study is used to study multiple outcomes. Whereas rarer outcomes, so I am going to evaluate what are all the causes for a malignant mesothelioma. That is a rare disease. So from you have to go find out who all the patients have malignant mesothelioma and find out the risk factors associated with the malignant mesothelioma. That is going to be a case control study. So you used to study rare outcomes is case control study. You used to study multiple outcomes because you are starting from the cause, then only you are moving to the effect. That is a case cohort study. This is a beautiful table column from Saveston, which enumerates the characteristics of each and every study and also describes the strength as well as the weaknesses. We'll briefly discuss the three important things: randomized control trial, cohort study, and a case control study. Randomized trial is used to establish the causal effects between the exposure and outcome, whether the exposure has resulted in an outcome which is ruled out by bias or any chance related errors. That is the randomized control study. It is very expensive. It can take a long period and not suitable for rare events. These are the weaknesses of the study. Moving on to cohort study. Cohort study is you are studying a particular condition or a disease in a defined population, and that requires a long time. It is usually a prospective trial, right? And you have selection bias. It can be expensive. Selection biases, you can define your cohort, right? So that selection of your defined cohort itself is a selection bias. Case control study, it can study rare outcomes and multiple exposures, relatively inexpensive. The possibility weaknesses include selection bias and a recall bias. Because when you ask a patient who had the disease about a particular risk factor, he will obviously link that risk factor to the causality of the disease. So there is a possibility of a recall bias in a case control study. So these are the three important studies we should know from a MCH point of view for examinations. Then moving on to evaluating the study quality. So we all tell that it's a well-conducted study or not well-conducted study. So for that, you need to have a validative report. So that relies on two important inferences. One is the internal validity, another is the external validity of the study. In simple words, internal validity relies on how well the study is conducted and the results are analyzed. That is, any cook-up has been done or whether the result is acceptable. That is what internal validity is about. Moving on to external validity. External validity is nothing but it relies on how well the study plan reflects the clinical question and how well the conclusions can apply to the scenarios outside the study. In brief words, how well it can be applicable in our real world scenario. That is what external validity is about. Then looking on the internal validity. The internal validity can understand the influence of bias, confounding, and chance. What do you mean by a chance? Chance is nothing but unpredictable randomness of events that might mislead the researchers. Bias, these are systematic errors in how the study subjects are selected or assessed. There can be a selection bias or there can be a ascertainment bias that results in inaccurate estimate of the differences in the outcome. And confounding, when there is difference in the comparison groups, like obese patients, the risk of complication is high. So if you are looking at the complication differences, whenever the obese patients were equally distributed between the two groups, then it is acceptable. When the obese patients are in the are more in the specific group, then there is a confounding bias of obesity. So that is how you should identify the factors. These are the internal factors which the researchers will find out whether the controls are matched or not. Only if they are matched, the results can be taken up for granted, or else the difference in outcome can occur due to confounding bias or confounding chances or confounding factors or occur due to a chance. Then looking at the chance, you have a null hypothesis when you start with the study. What do you mean by null hypothesis? It is based on the underlying assumption that when you're trying to compare the two groups, baseline, there is no difference noted. That is what is called the null hypothesis. Here, the researchers try to prove the null hypothesis or contradict the null hypothesis. Right? So that is how a null hypothesis is generated. Like you are trying to identify the difference between the two groups with the basic notion that there is no differences exist. Right? So that is the null hypothesis. Moving on to type 1 and type 2 errors, which are called the chance related errors. Type 1 is nothing but false positive. That is an alpha error. False positive meaning whenever there is no difference, but you note it down as a difference. That means you are rejecting the null hypothesis. I repeat again, type 1 errors or alpha errors are otherwise called as false positive. False positive meaning, that means the interpretation you make is there is difference between the two groups, wherein in reality there is no difference. That is regarded as false positive. That means you are rejecting the null hypothesis. Because null hypothesis is there is no difference. Here you are inferring as there is a difference. That means you are rejecting the null hypothesis is called as type 1 or alpha error. Moving on to type 2 errors, which is nothing but beta or a false negative. You accept the null hypothesis. That means there is obvious differences there, right? There is no difference in outcome when a difference is truly exists. That means when there is an obvious difference, you note it down as no difference. Here you accept the null hypothesis. So that is what a type B or a false negative. These are chance related errors. For a study to be agreed, these chance related errors should be less than 5%. That means 0.05. That is given by a p value. So p value is nothing but it indicates the probability that observed differences between the two groups might be due to chance alone. The threshold for significance is at a set p-value of 0.05, meaning less than 5 out of 10 could have occurred due to chance and not due to intervention. That is an acceptable thing. If anything more than 5 had occurred due to chance rather than being the intervention, the possible intervention that you use in the study does not have a causal association with the outcome. That is what the randomized control trial is about. Confidence interval is defined as a range of observed difference that would be expected if the same study was repeated an infinite number of times. It is the most important thing. That is what the confidence interval is more important. So that range also should be noted. So only if the confidence interval is agreed upon, that means it can be applied in real world scenarios, right? Because more the number of times you repeat the study, the range is almost going to be the same. That means it can be applicable in the real life scenarios. So now you can answer this question. Internal validity of the study is affected by all except confounding, agreed, bias, agreed, hypothesis testing is agreed. Hypothesis testing is nothing but the chance errors. So none of the above is the answer because all are affected. Very good. So this is a Schwartz-based definition. Internal validity is determining the degree that the results of randomized trial are accurate and consistent for the sample patients is called internal validity. It requires evaluation of whether it has been properly randomized or not, blinding protocol has been utilized, equivalence among groups, that means no confounding factors, and accuracy of analysis. External validity is to show a causative relationship between an intervention and outcome, whether it is generalizable to the clinical practice. So in external validity, these are the two things we use: numbers needed to treat and numbers needed to harm. Smaller the numbers needed to treat, that is to achieve a desirable outcome, like to achieve an overall survival of 12 months. For that, the numbers needed to treat is 20 patients or 100 patients. If it is a 20 patients, it is more efficacious intervention. So the drug is more efficacious. To prevent one death, you need to treat 20 patients. That is an achievable number. That means that intervention is equally efficacious. Numbers needed to harm. Higher the numbers needed to harm, the more safer the intervention. For example, you are using a chemotherapy drug. When the numbers needed to harm to achieve the effect as resulted in the study has mentioned this chemotherapy drug has resulted in an absolute survival benefit of 6%. To achieve an absolute survival of 6% in the real world scenario, the numbers needed to treat, if it is less, the intervention is agreed. The numbers needed to harm, if it is high, the intervention is safe. That is what the external validity is about. That means you are taking the exact clinical outcome and you are applying it to the real life scenario. You just rehearse the example which I have given. Now moving on to mean, median and mode. The value with the highest frequency observed used for nominal data collection is. It is a previous old MCQ question. That's why we are discussing it here. Obviously, it's a mode. Then let's analyze this. Match the following. You have the assessment tool on the left hand side and the study design on the right hand side. So since we have mentioned about the internal validity, so these are the internal validity measures that the research system has applied to validate the accuracy of this each and every study design. You have stroke assessment tool, you have consort guidelines, you have Picot framework, you have grade, and you have Prisma. We all know that consort is used for randomized control trial, grade for quality of evidence, and Prisma for meta-analysis. These three things we all must be aware. Picot is nothing but it helps us to analyze the research question, and Strobe is what to analyze the validity or the accuracy of a cohort study. Strobe is nothing but strengthening the reporting of observational studies in epidemiology. Consort is consolidated standards of reporting trials. GRADE recommendation for evidence, and Prisma for systematic review and meta-analysis. This is the Picot framework. Whenever you are trying to come up with a research question, this is the framework you should use to come up with the research question. P stands for population of problem, like the sample of subjects or the problems that will be addressed. That should be generalizable or acceptable. Intervention, what intervention you are going to do in this study, and what is the which control you are comparing it to, and what is the outcome you are expecting, and what is the time frame. Everything should be acceptable and generalizable. Only then the research question will be a complete one, or else that research question might answer a part of the question but will generate a lot of new research questions. So you always use this framework to have an ideal study. These are the various levels of evidence. Starting from level 1, level 1 is nothing but at least one large randomized control trial of good methodological quality. That good methodological quality is given by consort guidelines or the internal validity of the study. Then you have the small randomized trials or large trial of lower methodological quality. Next in ladder will be the prospective cohort and a retrospective cohort, and finally case series or case reports. These are the grade evidence quality. High quality grade is given by the definition. Further research is very unlikely to change the confidence. That means whenever the recommendation is high recommendation, there is no need for further researches in that area. Whenever there is low quality evidence or low quality, very low quality, in such areas you need to understand there is lack of high quality evidence, so you need to reconduct such tests in that area. So this is new here because we have a question on how to communicate the patient, like a breaking bad news question was asked in this recent NEET paper. So this is what I routinely use, or any communicating physician will use. Spikes protocol. Spikes protocol is you set up the place. So S stands for spike, that is setting up a place. You choose a private, comfortable place for the patient. You have so that you can have a one-on-one communication. You keep the patient at the same level, right? Then perception. You find out what the patient already know, what the patient or the family think that already is happening. Then you invite the patient, ask the patient what would they like to know. So the spikes protocol, you make the patient oriented, comfortable in the cabin. Then you allow them to talk, like what are all the things you already know. If you invite them, they themselves will tell this, like, yeah, I have certain disease, I might think that it might be a cancer. So if they are already aware of that, then it will be very easy for us to carry on the conversation and break the bad news. Then you find out, you provide them the knowledge, you explain the disease and the care options in the plain language. And during invite, you have to break the bad news. That is where the invitation happens. You have to give a warning shot. You prepare the family. So I may have some bad news for you to understand. Then you tell the disease. Then you explain the disease in detail. And finally, you respect their emotion and you respond with empathy. And finally, you summarize then you recap what we all spoke, and then you design what's next. So this is how we routinely do a breaking bad news. Whether patient alone is necessary or patient and attender is necessary is depending on the patient's choice. Ideally, the recommendation is to have the family members as well as the caretaker, that is the caretaker and the patient, to be involved in a breaking bad news session, not only the patient alone. So with this, we have completed the part 3 of general surgery. Then let's discuss about part 4. In part 4, we are going to discuss about perioperative care, wherein we discuss the preoperative assessment, intraoperative measures, postoperative care, and finally a bit about patient safety, incidents, and anesthesia aspects. So we'll start with a question with regard to the perioperative care. Which of the following surgeries are a predicted mortality between 1 to 5%? You have to understand surgeries with a mortality risk of less than 1% are low risk surgeries. Medium risk surgeries have surgeries with a mortality rate between 1 to 5%. And high risk surgeries are the surgeries with a predicted mortality rate more than 5%. Generally, these high risk surgeries incidence is around only 15%, and those surgeries remain the maximum cause for postoperative mortality. So you have to identify which of the following surgery is a medium risk surgery. Breast and thyroid surgeries, they are low risk surgeries. Open aortic surgeries or a peritonitis surgery, these are high risk surgeries. That means their mortality risk is more than 5%. Whereas an endovascular aneurysm repair is nothing but an elective disease which has a moderate risk. So you need to briefly understand this tabular column: high risk surgery, intermediate risk, and a low risk surgery. This is the tabular column. On the top is from the Bailey, and at the bottom is from the Sebastian. So from these, the other questions which can be asked include: you might not expect renal transplant. Renal transplant is a intermediate risk surgery, right? And the carotid endarterectomy is an intermediate risk surgery. And you have a splenectomy and cholecystectomy under intermediate risk surgery. Whereas a liver transplant or a lung transplant, lung resection, adrenal resection, esophagectomy, HPB surgeries. HPB surgeries are always high risk surgeries. Then let's answer this question. This question was based on ASA classification, that is American Society of Anesthesiologists. A 28 female, no comorbid or medical illness after traumatic brain injury and brain death, plan for organ donation will be classified under which ASA class? Organ donation comes under ASA class 6. These are the ASA grades and the predicted 30-day mortality as per Bailey. ASA grade 1 to grade 5 have an increased risk of mortality. It only takes certain things, but it is not that much specific. And ASA E includes the emergency operation. This is the ASA classification. ASA 1 is a normal healthy patient. ASA 2 is a patient with mild systemic disease, particularly they have a controlled diabetes, hypertension, and a CKD. ASA grade 3 is a patient with severe systemic disease. They have an uncontrolled diabetes, hypertension, COPD. Patient also is a morbidly obese patient, and patient requires dialysis and a recent MI or stroke or stents. All these comes under ASA class 3. ASA class 4 includes patient with a severe systemic disease that is a constant threat to life, right? So here it's a recent MI, that is less than 3 months, under stroke, and patient having a severe end-stage renal disease. Finally, ASA 5 include a moribund patient who is not expected to survive without the surgery, particularly include aneurysm, intracranial bleed, or other MODS picture patient. MODS peritonitis patients will have this ASA grade 5. ASA grade 6 is a brain dead declared patient whose organs are removed for donor purposes. This includes ASA grade 6. Right. So you all understand the NSQIP surgical risk calculator, right? So with this, we'll answer this question: which of the following is false regarding the American College of Surgeon, National Surgical Quality Improvement Program, Surgical Risk Calculators. So this American College of Surgeon has come up with a surgical risk calculator to find out how much risk that the patient will have as a consequence of this surgery pertaining to cardiac risk, pulmonary risk, DVT risk, etc. So likewise, they used several patient characteristics. They included 20 preoperative patient characteristics. After analyzing this characteristic, the surgery specific outcomes can be calculated, and they were able to generate 13 postoperative outcomes, and it can be used for all kinds of surgeries, not necessarily colorectal surgery. Of course, colorectal surgery was the first surgery that has been universally applied to calculate the surgical risk pertaining to colorectal surgery. So these are the 20 patient related characteristics. And you can even try this surgical risk calculator. Like you are planning for a radical hysterectomy, you can plan it, you can type it as a radical hysterectomy. There will be a clinical procedure terminology, procedural code will be there. If you apply the radical hysterectomy, it will enlist patient undergoing radical hysterectomy, and you have to input all the patient related characteristics with regard to the patient's age, medical comorbidities, and patient sex, emergency ASA class, etc. Whether the patient had any history of anemia, COPD, etc. Everything should be inputted, and it will generate the result, and you can take a printout and attach it in the case sheet, and you can use that for patient consent explanation. Like you as a patient undergoing this surgery will have a 5% risk of cardiac post-operative MI in the immediate post-operative period. You have a 3% risk of developing DVT, 2% risk of developing pulmonary atelectasis or pneumonia. You have for which your hospital stay will be prolonged. Like that, you can use it for explaining to the patient. Right. Now let's discuss about frailty. Frailty in geriatric patients can be assessed by frailty. What is frailty? Frailty is nothing but a weakness syndrome. Yeah, it's a combination of weakness, fatigue, weight loss, decreased balance, low physical activity, slowed motor processing, social withdrawal, cognitive changes, and vulnerability. That means it all occurs in a geriatric patients who is vulnerable to any kind of injury or stress. To test the frailty, you use the timed up and go test, that is a tuck test. What do you mean by tuck test? Step 1, as enlisted in the picture, you ask the patient to stand up from a seated position from a chair without holding the chair. Then you ask the patient to walk for 3 meters. Then you ask the patient to come back and sit. Ideally, this tuck time, this is called a tuck time. If it is less than 20 seconds, there is only 14% risk of morbidity, that is major morbidity. If the time taken by the patient exceeds more than 20 seconds, there is 50% risk of postoperative morbidity. There is more than 50% risk of major morbidity. Right. Which of the following is not a parameter of revised cardiac risk index? What do you mean by revised cardiac risk index? It's nothing but an RCRI. This is what you send the patient, the cardiologist would do when you send the patient for a cardiologist opinion for fitness for surgery. So these are the cardiac risk index of Lee. Following parameters: you have a high risk surgery, you have a history of prior ischemic heart disease, prior cerebrovascular disease, prior heart failure, diabetes mellitus on insulin, that is on insulin treatment, not on OHA, and renal insufficiency, the serum creatinine more than 2 milligram per deciliter. All these have a points. So this is given by an RCRI score. When the RCRI score of 0 or 1 or 2, that means less cardiac risk. RCRI score by 3 or 4, that is higher cardiac risk. You could see from this table, from 3 plus, you have a 11% risk of cardiac risk. What are the cardiac risks? You have a major adverse cardiac event or a post-operative MI. So when there is a more than 10% risk of post-operative MI or major adverse cardiac event, you need to subject the patient for further cardiological testing. Cardiac evaluation should be done in the form of angio to find out whether there is any requirement for any preoperative stenting, etc. So prior peripheral vascular disease is the not a parameter. High risk surgery is there. Preoperative creatinine level is the insulin requirement in diabetes. So this is with regard to coronary revascularization. So when RCRA is 3 or 4, you do an angiogram, and then when the testing shows abnormality, you need to subject the patient for either a plasty or a stenting. When you have done a plasty, that means dilating the vessel. You need to put the patient on antiplatelet cover. That antiplatelet cover should be there for a period of 2 weeks. When you put a patient on stent, previously people used bare metal stent wherein you need to provide the antiplatelet cover for 1 month. Recently, all use drug-eluting stent where the patient should be kept on dual antiplatelet treatment for at least 1 year. The aim is to prevent the stent thrombosis. So what all the patients who require coronary revascularization, RCRA 3/4, right? And you avoid elective surgery. If the patient had recent MI, you avoid surgery for 3 to 6 months. Angioplasty, you avoid surgery for 2 weeks. In patients on bare metal stent, you avoid surgery 1 month, and drug-eluting stent for at least 6 months. So I am just putting the same content here. DAPT is nothing but dual antiplatelet therapy. That means you put the patient on aspirin, and then you have a antagonist, P2Y12 antagonist, include clopidogrel, prasugrel, or ticagrelor. You look at the type of procedure and the antiplatelet cover requirement. For balloon angioplasty, you require 14 days of antiplatelet cover. For bare metal stent, you need 1 month of antiplatelet cover. And for drug-eluting stent, you require 1 year of dual antiplatelet cover. Suppose you are planning for surgery in this patient. How long should you wait? For emergency situation, there is no other go. For elective surgeries, how long should you wait? For recent MI, ideally is at least 3 to 6 months according to Bailey and 4 to 6 weeks according to Sebastian. Balloon angioplasty, you wait for 2 weeks, bare metal stent for 1 month, and drug-eluting stent at least 6 months. Because if you're planning for surgery, you need to stop these drugs for some while, and during the time, the patient will have a further precipitation of an attack. That is why you need to have a minimal waiting period of 2 weeks or 1 month or 6 months based on the procedure that the patient had undertaken, provided it's an elective surgery which can wait for such time. If not, you need to coordinate with the cardiologist. Risks and benefits should be analyzed and then proceed with the surgery with the help of supportive drugs or alternative drugs. Now let's discuss this question. This question is framed on the aspect whether the patient should require. Can I answer the questions at the end? Right? Let's complete this thing, and I will answer the questions from the chat box at the end of the session. 48 female, so known hypothyroid and history of chronic steroid intake of prednisolone 20 milligram strength daily for almost 6 months. Now planned for elective emergency surgery for intertrochanteric fracture. What is the perioperative precautions undertaken to prevent the Addisonian crisis? First, you must understand what is an Addisonian crisis. Addisonian crisis usually happens whenever there is any stress, there is no stress response. So surgery itself is a stress, right? So what is the stress response? Your hypothalamo pituitary adrenal aldosterone axis. That should be intact. That is HPAA should be intact to achieve a stress response to surgery. When will the HPAA won't be intact? So HPAA is suppressed in dose 5 milligram or more of prednisolone. 20 milligram. 20 milligram or more of prednisolone for a duration of more than 3 weeks. When you put the patient on steroids on a dose equivalent of 20 milligram of prednisolone for more than 3 weeks, the HP axis will be suppressed. In such cases, you need to provide exogenous steroids to counteract the surgical stress response. HPAA is not suppressed when the dose is up to 5 mg and less than 3 weeks. So for patients, you put some patients on steroids for 1 week, then you taper it. In such cases, you need not provide an exogenous steroids because the HPA axis won't be that much disturbed. So it can elicit a surgical stress response whenever surgery is being done. So when it is suppressed, so in this patient, a 20 milligram strength for 6 months. Here the HPAA is suppressed. So you need to provide exogenous steroids, particularly for an emergency surgery for a fracture. That means it is a major surgery. So you always start with a start dose of 100 mg IV followed by 50 mg IV every 8 hours for 48 hours and then you resume the usual dose. These are the additional exogenous steroid that the patient will require to counteract the surgical stress response. If not, since the axis has been suppressed, the patient will go into Addisonian crisis. Addisonian crisis is nothing but a medical emergency and it can even lead to death. Right. So now let's understand the drugs and their characteristics. So these are the drugs which should be stopped or withheld dash days before surgery. Antiplatelets like aspirin can be continued during surgery if the risk is so high, or it should be stopped for 1 day. Antiplatelets, ideal recommendation is 5 to 7 days. What are antiplatelets? You have clopidogrel, ticagrelor, and prasugrel. Warfarin, 5 days is sufficient. Direct orally acting anticoagulants is factor 10A inhibitor and factor 2A inhibitor. What are 10A inhibitors? You have an apixaban, rivaroxaban, etc. And 2A inhibitor include dabigatran, etc. So these requires 2 to 3 days of stoppage. Heparin, if you are using unfractionated heparin, 6 hours. If you are using a low molecular weight heparin, it is 12 hours. Oral hypoglycemic agents, skip the morning dose. Hormonal treatment should be stopped for 4 weeks, particularly if the patient is on tamoxifen or letrozole. Steroids, you can continue because to counteract the stress response, you will require it. Beta blockers, you continued. Statins to be continued. AC inhibitors and ARBs should be stopped on the day of surgery because to prevent the renal vasoconstriction. To prevent the renal vasoconstriction, because whenever any hypotension is happening during surgery, if you are putting the patient on ARB or AC inhibitor, further renal vasoconstriction will happen. So what will happen? The patient will have precipitate an acute kidney injury by giving AC inhibitors and ARBs. That is why you need to avoid AC inhibitors, ARBs on the day of surgery. So if you look at this table, you have a drug name on the left hand side and you need to identify the reversal drugs. For heparin, the reversal is protamine sulfate. Warfarin, you have a vitamin K injection. You can have a prothrombin complex concentrate, or you can use a FFP. For dabigatran, you have a drug called idarosizumab. For 10-HE inhibitors, you have a drug called andexanet alpha. So with this, we have completed the, we are not completed it. So we have one more question left. Suppose the patient is on a warfarin due to heart valve replacement, that is a valve replacement, and planned for a major elective surgery. Which of the following is true? Warfarin can be reversed with protamine. Is it true? Heparin is only reversed with protamine. This is a false statement. Warfarin to be stopped for 10 days before surgery. Ideal thing is 5 days. In a replacement heart valve patient, you cannot stop the drug. So that is also a false statement. As stopping warfarin for 5 days leads to 9 days of subtherapeutic anticoagulation levels. Bridging with heparin is required to prevent thromboembolism. That is a true statement. Let me explain you this. Bridging therapy with heparin is required in all cases of stoppage of warfarin. That is false. If it is a low risk, low cardiac risk patient and a low risk of bleeding or a high risk of bleeding, in such cases, you can stop the warfarin and you need not bridge the patient on heparin. Whereas in the heart valve patient, if you stop the warfarin for 5 days and you restart the warfarin after surgery, again the anticoagulation level, it will take 3 to 4 days to achieve the anticoagulation levels, therapeutic levels. So that means 9 days the patient will not be on anticoagulation. So that will precipitate thrombosis, atrial fibrillation, etc. in a valve kind of patient. In such patients, only bridging therapy is required. Not all patients require bridging therapy. So this is a true statement. Then with regard to preoperative fasting, this question was framed. A 9-month-old baby scheduled for an elective surgery was bottle fed with cow's milk. 9 months na. So now they are giving cow's milk. What is the minimum fasting period required for this boy? Right? So the answer is 6 hours for cow's milk. The aim of preoperative fasting is to reduce the gastric volume and minimize the aspiration risk. According to the ASA guidelines, based on the ingestive material, the minimum fasting period required for clear liquids is 2 hours. If you consumed clear liquids, minimum fasting period for 2 hours is required. For breast milk, 4 hours. Infant formula or non-human milk like cow's milk, you require 6 hours. A light meal requires 6 hours. Fried foods and meal like biryani, french fries, etc. you require 8+ hours. So this is the ASA guidelines for fasting. So with this, we have completed the preoperative assessment. Now let's move on to anesthesia, anesthesia per se. Let's start with muscle local anesthetics. Identify the wrong match. Bupivacaine is well known for cardiotoxic effects. Prilocaine is a drug of choice for total intravenous anesthesia, that is bias block. Lignocaine topical spray we all know because we all used to do endoscopies for which you use a lignocaine spray. Lignocaine and methemoglobinemia is the wrong match because prilocaine is associated with methemoglobinemia. So you need not read in anesthesia in detail. Let me put on the important tabular columns from Sebastian, Schwartz and Bailey. You just follow this tabular column alone. Right? You have on the left hand side, you have a lignocaine, bupivacaine, prilocaine. These are the commonly used local anesthetics. Lignocaine, the dose is 3 mg per kilogram. Bupivacaine, 2 mg per kilogram. Prilocaine is 6 mg per kilogram. The advantage of lignocaine is early onset and short acting. Advantage of bupivacaine is long lasting but more cardiotoxic. Prilocaine least systemic toxicity but causes methemoglobinemia. This prilocaine is used in TIVA, that is total intravenous anesthesia, or otherwise called as Byers block. Right? What is the use of adding adrenaline to local anesthetic? By adding adrenaline, it can cause local vasoconstriction. So, because of the local vasoconstriction, the following 4 advantages are going to happen. It increases the onset, prolongs the duration of action because local vasoconstriction, the drug escape rate is very less, and it limits the systemic spread, so more dosage can be given. So with adrenaline, you can give lignocaine up to 7 mg, that is twice the dose you give without adrenaline. And then you can increase by the advantage of systemic spread, and it increases the dosage of the drug. Now let's discuss about muscle relaxant. We have discussed about local anesthetic. Now we will discuss about muscle relaxant. The drug that gets cleared by non-enzymatic Hoffman degradation. Non-enzymatic Hoffman degradation is atracurium. This is atrac and cis-atrac are not metabolized by liver or kidney. Broadly, the muscle relaxants are classified into two: depolarizing and a non-depolarizing muscle relaxant. Depolarizing muscle relaxant, you have only one drug, that is a suxamethonium. Causes rapid onset, rapid relaxation, quick onset, very short duration for only 5 minutes. So every 5 minutes you need to repeat that. So it's used for rapid sequence intubation, but the main disadvantage being it causes hyperkalemia, muscle pain because of the fasciculations, can cause anaphylactic reactions, and malignant hyperthermia is an increased risk. With regard to non-depolarizing blockers, these are more predictable, right? They require careful monitoring, and the main advantage is even when they are long lasting, they can be reversed by neostigmine or a newer drug called sugammadex. It's a more predictable fashion and more preferred by anesthetic for long lasting effect. For rapid sequence intubation, people used to give Saxa, and then they maintain the muscle relaxation with vecuronium or atracurium. These are the common drugs: vecuronium, atracurium, rocuronium. These are non-depolarizing. Saxa is a depolarizing muscle relaxant. Right? For MCQ point of view, malignant hypothermia risk is with Saxa. Vecuronium is dependent on liver and kidney, so it cautious should be used in CKD patient and liver disease patients. In such patients, you will prefer a atracurium. Atracurium is more prone to cause the anaphylactic reactions. So this is with atracurium. Vecuronium, rocuronium, even though they are long lasting, long duration of effect, they can be reversed with neostigmine and sugammadex. So we have completed local anesthetic, we have completed the muscle relaxant. Now we'll discuss about general anesthesia. General anesthesia, we have inhalational anesthetics and intravenous anesthetics. This question is related to inhalational anesthesia. The inhalational anesthesia that is potent and can be used for induction. Induction is you induce the patient. Then general anesthesia, two phases. One is an induction and a maintenance phase. Generally, for induction, people use intravenous anesthesia, and for maintenance, they use inhalational anesthesia. So, one inhalation anesthesia that is potent and can be used for induction is sevoflurane. That is why it is preferred in children. So, this is the table column that tells us the potency as well as the suitability for induction. The table column on the right gives us the potency. Nitrous is a weak potent drug, whereas sevoflurane, desflurane are more potent drug. They have a rapid onset and rapid emergence, and the suitability for inhalation anesthesia is only for CO, not for desflurane. Why? Because it is an airway irritant and it is very expensive. Sevoflurane, it's not pungent, but it is more expensive. It is used in children. Induction agent for children is sevoflurane. Child or pediatrics is sevoflurane. With regard to nitrous oxide, it has no odor or taste and pungency. Analgesic effect will be there. It is very inexpensive, but the main disadvantage being increased nausea, vomiting, airspace expansion. Airspace expansion is very dreaded effect with the help with regard to nitrous oxide. If the patient has put on nitrous oxide for so long, you cannot do lap surgeries. The bowels will get distended. Then moving on to the intravenous induction agents. The commonly used is propofol and ketamine. Propofol, main this thing is it is a very good bronchodilator, so it is used in the induction of asthmatics. That is very important MCQ point. The main side effect being hypotension. Then moving on to ketamine. Ketamine you have that can be used for rapid sequence induction in asthmatics, right? But the main disadvantage being it has a psychotropic effects, so it can cause emergence delirium. Etomidate is a cardiostable drug. Okay, but the side effect being adrenal suppression can happen with etomidate. Thiopentone is an older drug, it is inexpensive, but the main side effect being hypovolemic and suitable for induction in many patients. For MCQ point of view, best drug for rapid sequence induction is ketamine. Psychotropic effects, emergence delirium with ketamine. Cardiovascular stable is etomidate, but has side effect of adrenal suppression. Propofol, best for asthmatics, most commonly used induction agent, but the side effect being hypotension is the side effect with propofol. Now, can you answer the question? What is the preferred drug for rapid sequence intubation? We all know it's ketamine. Then there was a question about malignant hyperthermia, right? Which of the following is true regarding malignant hyperthermia? What is malignant hyperthermia? It is an autosomal dominant disease which is caused by a mutation in the ryanodine receptor RYR1 gene, which encodes a ryanodine receptor. It occurs in 1 in 250,000. It is an acute episode of hypermetabolism, right? What this ryanodine receptor happens, it will go and increase the intracellular calcium levels and put the muscle into contraction. So these are the drugs which can cause this malignant hyperthermia. These include CO in all inhalation anesthetic and one depolarizing muscle relaxing, that is a saxamethadone. What happens as a result of prolonged muscle contraction? There will be increase in temperature leading on to fever, tachycardia, tachypnea, hyperkalemia. Why? Because the cellular death will happen and lot of potassium will be released. And finally, acidosis. How to identify the patient has developed malignant hyperthermia? Increase in EtCO2, that is end-tidal carbon dioxide, the earliest harbinger of malignant hyperthermia. So what you should do when you suspect hyperthermia, you discontinue the inhalational agents. You start on IV dantrolene, which is the emergency drug. You have 2.5 milligram per kilogram every 15 to 10 to 15 minutes till everything normalizes, till the EtCO2 comes to normalcy. Then you supportive treatment is required for hyperkalemia, fever by giving tepid sponging, cool drugs and cool IV fluids, and also you treat the arrhythmia in view of temperature fluctuation. So can I answer this question? Which is this true regarding the malignant hyperthermia? Dandruff sodium is used for treatment is a true statement. A simple screening test is available for diagnosis. It's a false statement, or else we could have incorporated in all our pre-anesthetic schedule. Clinical manifestations are due to high levels of intracellular calcium and not magnesium, which is a false statement. And it has no genetic predilection. It is an autosomal dominant disease. So that is also a false statement. Right. So identify the name of the drug that acts on opiate as an agonist and a noradrenaline reuptake inhibitor. It's nothing but a painkiller, that is a tapentadol. Right. So this we have completed the preoperative assessment as well as the anesthesia per se. Now we'll move on to postoperative care, immediate postoperative care followed by postoperative complications. Which of the following is recorded in bedside of the patient as part of the National Early Warning Score? It includes all: pulse, BP, respiratory rate, saturation, temperature, and the level of consciousness. This is the National Early Warning Score. It is used in Western countries to identify and patients who might require a immediate response or a shift to ICU. It's a score that has been developed to prime the staff about when to call upon the doctor or when to call upon the intensivist for an appropriate response to the patient. Which of the following is not a part of step-down criteria from PACU? PACU is nothing but post-anesthesia care unit. So, generally from PSU, what we'll expect? We expect the patient to be out of the anesthesia completely and the anesthesia effects and have a stable vitals and does not have pain, or the pain can be managed with medications and not nauseous. Able to consume orals is not a criteria. Not all surgeries will require immediate oral consumption. So this is the step down criteria. Patient should be awake, oriented, have stable vital signs, able to maintain airway and breathe properly, with adequate control of pain, no vomiting, no nauseous, and anesthesia block has weaned, and there is no evidence of surgical complications like bleeding, etc. So this is the tabular column from Schwartz that has given up the 3 phases that has been used in enhanced recovery after surgery. In a preoperative phase, it always starts with patient education, right? And you set the expectations to the patient. Then you advise them for smoking, alcohol cessation, rehabilitate the patient, reduce the hours of fasting, antibiotic prophylaxis, thromboprophylaxis should be given, minimize the bowel preparation. Intraoperatively, our aim is to provide pain blocks, aim for a minimal invasive surgery to have the decreased injury response, goal-directed fluid therapy, prevention of nausea, vomiting, avoid tubes, drains, and lines, and maintain the patient in a normal temperature. Postoperative care, again, you maintain the goal-directed fluid therapy, normovolemia, normothermia, prevent the nausea, vomiting, early ambulation and early feeding to decrease the metabolic response, pain relief to decrease the neuroendocrine response, early Foley removal and early discharge efforts. Now let's discuss about the common systems, right? System-wise related postoperative complications that the patient might get. First, we'll start with the neurological system, wherein we are going to discuss about acute postoperative delirium. What do you mean by delirium? Delirium is nothing but a state of confusion along with disturbance in focus, attention, or awareness over a short period of time. It generally occurs in elderly patients who are undergoing major surgeries. What is the cause for this delirium? Number one, already there is cognitive decline and decreased cerebral perfusion pressure and alteration in the blood-brain barrier. Next, you have the most important thing, that is neuroinflammation, secondary to inflammatory cytokines, secondary to the surgery or trauma or the injury response. And finally, there is changes in the neuroendocrine levels. The incidence of delirium being 5 to 50%, the patient can present as a hypoactive delirium or a hyperactive delirium. The management generally includes you avoid restraints. Why? Because it will stimulate the hyperactiveness of the patient. You maintain normal sleep-wake cycle, reduce unnecessary stimuli. Eyeglass and hearing aids can be provided to uh, determine the normalcy recovery period of the patient. You allow the family and the friends to reorient and reassure the patient. Apart from these routine measures, you always rule out the organic causes for delirium. You try to correct the sugar, try to correct the dehydration, control the pain, correct the electrolyte disturbances, etc. Try to remove all tubes at the earliest so that the patient feel normal. Early mobilization, support of the ICU bed soon. The delirium, if it is hyperactive delirium, you need to give IV haloperidol. If the delirium is due to alcohol withdrawal syndrome, you can provide a diazepam. So can I answer this question? False statement about acute postoperative delirium is incidences 5 to 50%, that is true. Can present with poorly responsive and depressive syndrome, that is a hypoactive delirium, that is also a true statement. Mini cough test predicts the risk of postoperative delirium in aged patient, that is also true. What do you mean by a mini cough test? Nothing but a test, you test on a patient, right? You talk with the patient and you give 3 words to the patient. Ask the patient to repeat those 3 words. That is, recall 3 words, draw a clock. That is mini clock test. You provide 3 words to the patient. You ask the patient to recall the 3 words to you. Ask the patient to repeat the 3 words. Next, you ask the patient to draw a clock. You clearly describe how to draw a clock. You put a larger circle, put the hours, then you set the hands to certain time. The patient is able to do that, then it's fine. Then after completion of drawing the clock, you again ask the patient to repeat those 2 words which you said already. Based on these tests, you can have various scoring points, right? Like scoring point, and the points are more than 4 or 5. It indicates patient have a less risk of developing delirium. If the score is less, patient has a high risk of developing delirium. Benzodiazepines are used to treat hyperactive delirium. That is a false statement. For hyperactive delirium, you will use a haloperidol. Benzodiazepines are used for alcohol withdrawal syndrome. Right. Now let's discuss about pulmonary embolism. Which of the following scoring system is used to predict pulmonary embolism? Caprini score, Rogers score, Padua score, all these are used to predict deep vein thrombosis. Wells score is used for pulmonary embolism. Wells score and Geneva score. These are the 2 scores used to predict the pulmonary embolism. This is a 2-level pulmonary embolism Wells score from Bailey and Lowe. These are the clinical feature and the points for the appropriate clinical features. So based on the score, the patient, we can put the patient as this patient as likely to have a pulmonary embolism and this patient as less likely to have a pulmonary embolism. You can arrive at this diagnosis. Based on this interpretation, you can subject the patient for further evaluation. What evaluation? When the chance of pulmonary embolism is high, that is Wells score 4. P is likely is Wells score more than 4. That is 5 or more is P likely. P unlikely is Wells score 4 or less. When the patient is high likely to have a pulmonary embolism, you put the patient, subject the patient for CT pulmonary angiogram or a ventilation perfusion scan. If it is positive, you treat the patient for pulmonary embolism either by catheter directed thrombolysis or you do a lysis with tenecteplase or alteplase. If it is negative, we subject the patient for D-dimer assay. If the D-dimer is positive, that means there is some embolism, but not in the pulmonary embolism. So where it could be in the deep veins of the leg. So you do a patient, subject the patient for a proximal leg vein scan. If it is negative, it rules out the pulmonary embolism. Where the pulmonary embolism is unlikely, you at least do a D-dimer assay. If it is negative, it rules out thrombosis. If it is positive, you do a CT pulmonary angiogram. Right? So this is how the Wells score is used to predict the pulmonary embolism and help us to subject the patient for further investigation. So with this idea, I have created a question. What to be done next in a suspected pulmonary embolism patient with a Wells score of 3 points? How to go about this question? You need to identify whether there is likelihood of pulmonary embolism is there or not. Wells score 3 points, meaning pulmonary embolism is unlikely. In an unlikely situation, what is the minimal investigation you would do? You do a D-dimer assay. Right? If it is likely, you do a CT pulmonary angiogram. Right. Which of the following statement is wrong regarding thromboprophylaxis and therapeutic management of venous thromboembolism? Low molecular heparin are preferred in patients with renal failure to prevent heparin-induced thrombocytopenia. Low molecular heparin are generally contraindicated in renal failure. Okay, so this is a false statement. Thromboprophylaxis for cancer patients are continued up to 7 to 10 days post-operatively. That is a true statement. Prophylaxis, right? Long-term anticoagulation is preferred with direct oral anticoagulants. That is also a true statement because you start the patient on heparin and discharge the patient on direct oral anticoagulants like apixaban, rivaroxaban, etc. Low molecular weight heparin is preferred over unfractionated heparin in initial anticoagulation. That is also a true statement because it is predictable. What is venous thromboembolism? You all know Virchow's triad given by venous stasis, endothelial injury, and hypercoagulability. 40% of the patients who develop DVT, they undergo unnoticed. These are the following scoring system to predict the risk of developing DVT. Rogers score, Caprini score, Wells score, Improve score, and the Padua score. Right? Lower limb deep veins, whenever there are any thrombosis, only will have a risk of developing a pulmonary embolism. This is the important MCQ point. Then moving on to the VTE prophylaxis guidelines in adult surgical patients based on the risk category calculated from the scoring systems. We have a very low risk, moderate, and a high risk. For a very low risk category patients, that includes there is 0.5% risk of developing DVT. In such cases, immediate postoperative ambulation itself is sufficient, no need for any prophylaxis. In a low risk patient who have a 1.5% risk of developing DVT, you need to provide at least a mechanical prophylaxis in the form of DVT stockings. What is the function of this mechanical prophylaxis? These pneumatic compression devices or stockings, they increases the blood flow and decreases the venous chases. That is one part of Virchow's triad. Next, it increases the tissue plasminogen activator. That means fibrinolysis is pronounced. So whenever a clot has been formed, it will immediately lyse. So these are the basic principles behind using a mechanical prophylaxis. Moving on to moderate or high risk, wherein the risk of DVT is more than 3 to 6%. In such cases, you need to put the patient on pharmacological prophylaxis. What pharmacological prophylaxis you will advise the patient? You will put the patient on low molecular weight heparin. Based on the studies, you have a dalteparin and an enoxaparin. Enoxaparin dose is 1.5 mg per kilogram OD for 5 to 7 days after surgery. It should be started within 12 hours after surgery, right? So this is the venous thromboembolism prophylaxis. The other drug is fondaparinux, which is in a dose of 7.5 mg per kilogram OD. Extended prophylaxis is giving up to 4 weeks. It is commonly done in cancer patients. There is another well score criteria for DVT. We already discussed the well score for pulmonary embolism, where pulmonary embolism is likely or less likely. Likewise, for DVT, DVT is likely when the well score is 2 or more. DVT is unlikely when the well score is only 1 point. Because you have a negative point here. That's why the scores are very low. Likewise, when the DVT is likely, that is well score 2 or above, the initial investigation, likewise for pulmonary embolism, you do a CTPA. For deep vein thrombosis, you do a proximal leg vein scan. If it is positive, you treat as per DVT. If it is negative, you again do a D-dimer. If it is positive, you repeat the scan after 1 week. If it is negative, that means you have ruled out DVT. Likewise, when the DVT is unlikely, you do a D-dimer. If it is positive, you do a proximal leg vein scan. If it is negative, that means you have ruled out a DVT. Right. Now let's discuss about another post-operative complication, that is post-operative nausea and vomiting, which is not considered an increased risk factor for nausea vomiting. Nitrous, nauseous vomiting will be there. Opioid also is there. That is why in enhanced recovery after surgery, you limit nitrous, you limit the opioid use. Female sex is a risk factor, whereas smokers generally don't have increased risk of nausea vomiting, whereas non-smokers have an increased risk. So these are the risk factors: nitrous, opioids, pain, and dehydrated. The risk score include Apfel and Coiurenta score. This is an Apfel score. You have a female sex, prior motion sickness and nausea vomiting, non-smoker, and a post-operative opioid treatment is planned. Based on the score, you have a risk of post-operative vomiting from 10, 20%, 40, 60, and 80%. So what are the consequences of post-operative nausea vomiting? You can have an increased risk of aspiration. Because of the vomiting, the increased intra-abdominal pressure can cause wound dehiscence and can precipitate bleeding, and even can increase the intracranial pressure leading onto hemorrhage. So how to treat? You treat the other risk factors like cause dehydration aspect, pain aspect you treat, but don't use avoiding opioids. Then you treat the dehydration. The combination drugs will be a 5-HT3 antagonist, that is ondansetron or emised, with a steroid, that is dexamethasone, and then you even add an antihistaminic, particularly first generation antihistaminics like meclizine, cyclizine, chlorpromazine, etc. Then this is the most dreaded intraoperative complication, that is venous air embolism. Generally, venous air embolism, it occurs in 5 to 15%. Can you believe it? Right? A high risk in neurosurgery patients, particularly when they are operating near the cranial venous sinuses, a small venous entry tear, the outside air will enter and it will go and block the right heart. Vascular surgery while making a venotomy. That is why while closing the venotomy, you de-air, you release the clamp, let the air come out through the final stitch, then you will make a final stitch to prevent the air entering into it. Laparoscopic surgery, while CO2 is there, pneumoperitoneum is there, you injure the vessel, through the vessel, the air can enter into it. And also in endoscopic thyroid surgeries or endoscopic neck surgeries, you might allow CO2 to enter, causing air embolism. So this air embolism, even 5 ml is sufficient, can enter into the right heart, right atrium, right ventricle, finally enter into the pulmonary artery and get stuck there. And it causes severe right heart failure symptoms. So the patient will have a fall in EtCO2. Can you recollect a rise in EtCO2 is seen in malignant hyperthermia, whereas fall in EtCO2 is seen in venous air embolism. And during class, I have described about bronchovenous air embolism. Bronchovenous air embolism affects the left heart, whereas venous air embolism affects the right heart. Remember this. So management, you close the surgical area, sprinkle water with saline soaked pads, then you do the Durance maneuver. What is Durance maneuver? You put the patient in Trendelenburg position, that is head low, and a left lateral decubitus. Left lateral decubitus, head low position. Right? So what will happen? The air will enter into the right ventricle. Right? By putting the patient in a Trendelenburg, from the air from the pulmonary artery will enter into the right ventricle. Right? Putting the patient in the left lateral decubitus, water bubble will enter into the right atrium. Then with the help of a central venous catheter, you can aspirate the water bubble. This is called Durance maneuver. So management includes all except you cut down the nitrous because it will expand the air bubble and supply 100% FiO2. That is true. Left lateral decubitus and reverse Trendelenburg position. If you reverse Trendelenburg position, the water will be air bubble will be in the pulmonary artery itself. It will come to the right ventricle and the right atrium. So this is a wrong statement. Aspiration through CVP catheter is a true statement. CPR in supine position if the patient develops arrest, that is also a true statement. Right. This should be an easy peasy for you. A 67 female underwent lap chole. On 5th postoperative day, the patient had fever, chills, rigor. USG revealed a 400 cc collection. Patient underwent pigtail drainage of the collection. What grade of Clavin Dindo classification? Any postoperative complications for universal acceptance, we are using a Clavin Dindo classification. Any postoperative complication which require intervention radiologist procedure done under local anesthesia will be classified as grade 3A. Looking at the grades. Grade 1 is any deviation from the normal postoperative course without the need for pharmacological treatment. You give routine antipyretics, analgesics, physiotherapy, etc. Grade 2 is you give pharmacological treatment. Apart from that, you allow for grade 1, which includes blood transfusion, TPN or grade 2. Antibiotic prophylaxis is grade 1, right? Prolonged antibiotic, it comes under grade 2. Grade 3A is intervention not under general anesthesia. 3B is intervention under general anesthesia. Grade 4A is life-threatening complication with single organ dysfunction and multi-organ dysfunction. And grade 5 is death of the patient. This is an easy question for you. Which of the following statements regarding seroma is false? It is more common in inguinal block dissection surgeries. That is a true statement. Hernioplasty has higher incidence than herniorrhaphy because keeping a mesh will elicit more reactions. Seroma after radical mastectomies are treated with repeated aspirations. True statement. Initial management is drainage with CRT placement. Initial management is you can drain it with the help of aspiration, or in repetitive situation you can place a suction drain. This is a false statement. Well, this is the next question for you. A 68 male, chronic tobacco, alcoholic, hypertensive, cardiac patient on dual antiplatelet treatment for a head and neck surgery for a head and neck cancer after appropriate stoppage of drugs. No other medical disease and blood parameters in no other medical disease was observed. Blood parameters are in normal levels. What is the risk of bleeding following this surgery? Any head and neck surgery will have a high risk of bleeding. So the answer is simple. But this question has been framed based on a bleeding risk score that is called as blood score, evaluating the bleeding risk post surgery. These are the following parameters. Score of 0 to 1 has a low risk of bleeding, whereas a score of 2 has an intermediate risk, 3 or more has a high risk of bleeding. High risk of bleeding surgeries include cardiovascular surgery, orthopedic surgery, head and neck surgery, or any surgery more than 45 minutes. Whereas low risk surgery, hernia, cholecystectomy, or surgeries less than 45 minutes. Which of the following evidence statements regarding abdominal wound dehiscence is wrong? Suture to wound length of 4:1 is recommended. That is a true statement that is given by Jenkins rule. No difference in incisional hernia noted between midline laparotomy closure using Prolene versus PDS. That is a true. That is why we are using PDS sutures now. 1 centimeter depth, 1 centimeter progress stitch is recommended, which is a false statement because as per stitch trial, large bite versus small bite includes, that is 0.5 by 0.5. Bite has less incisional hernia rates. You have 14% risk, whereas for a 1 centimeter depth, you have 21% risk. Prophylactic mesh reinforcement proven to be effective in obese patient and aneurysm surgery patients. That is also a true statement. Then let's discuss about abdominal wound dehiscence. Which of the following statement regarding abdominal wound dehiscence is wrong? It most common during the proliferative phase of wound healing. With regard to wound healing, it occurs during the first week. During the first week will be the inflammatory phase. It presents with serous sanguineous discharge from the wound site. That is true statement. Infection, most common cause. Late presentation after 2 weeks, usually not require immediate exploratory surgery. That is also a true statement. When abdominal wound dehiscence will require surgery, only when there is evisceration and massive bleeding or collection. Okay, surgery in evisceration of the contents are associated with massive bleeding. These are the two indications for abdominal immediate surgery following abdominal wound dehiscence. Late presentation, in such cases, if you try to do, you will try to injure the bowel to the maximum, leading on to fistula and other septic complications rather than cure to the patient. Regarding postoperative fever, which is a wrong statement. The most common pathological causes atelectasis. That is a true statement. Catheter related bloodstream infection requires proof of catheter tip culture being positive, which is a false statement. Interleukin 1,6 TNF alpha mediates a physiological fever is a true statement. Wound infection, pulmonary embolism are the causes for fever after 1 week of surgery. That is a true statement. For CLABC, that is catheter related centerline associated bloodstream infection, you don't require a proof of catheter. Instead, you take the blood sample from through the cannula and another blood sample from the peripheral vein. You compare the bacterial counts and then you decide, you arrive at the diagnosis. That is how you identify it. So with regard to postoperative fever, what is the definition of a post-op fever? Any patient with temperature more than 38 degrees Celsius for 2 days, or at least one occasion the temperature exceeds 39 degrees Celsius. The common causes being first 2 days. It's mainly due to SIRS response, which is physiologic, mainly due to circulating pyrogenic cytokines interleukin 1 and TNF alpha, particularly after major surgery or trauma or burns. From day 3 onwards, day 3 you have a specific cause, that is atelectasis. Day 4, urinary tract infection. Day 5, thrombophlebitis from cannula related infections. Day 6 to 10, you have wound infection, that is surgical site infection. And day 7, you have DVT or pulmonary embolism as the cause for fever. Then regarding respiratory complications in the postoperative period, which is a true statement. Aspiration pneumonitis is a common infective complication seen within 48 hours. Pneumonitis, aspiration is a inflammatory condition. Pneumonia is an infected thing, whereas pneumonitis is an inflammatory complication, which is a false statement. Anesthetic agents decrease the FRC, leading to atelectasis. Yes, that is the main cause for post-op atelectasis. The functional residual capacity of the lungs will be reduced because of the use of the inhalation anesthetics. So that's why you advise the patient to put on spirometry to recruit more alveoli and to prevent atelectasis. VAP, that is ventilator associated pneumonia, has increasing risk with increasing days of ventilation. It usually the reverse. VAP is more commonly seen in initial 1 to 3 days of ventilation and not beyond that. Higher the pH and volume of aspirate, greater the severity of pulmonary damage. With regard to aspiration, lower the pH because more acidic thing will have greater damage, and that is also a false statement. Regarding neurological complications in the post-operative period, which is a wrong statement. Most common complication is post-operative delirium, which which is seen in around 50%. Most common stroke, mostly an ischemic stroke secondary to an embolism. Embolic stroke is the most common. Recombinant tissue plasminogen activator should be given in case of an ischemic stroke. You have no risk of bleeding due to major surgery. That is a true statement. Elective surgery should be withheld for at least 6 months in a patient with history of recent stroke. That is a true statement. Which of the following anastomosis has the lowest rate of anastomotic leak? Pancreatico-enteric anastomosis, that is the Achilles heel of Whipple's, it's a high risk. Colorectal, again, below, if it's below the level of peritoneal reflection, it is very high risk. Above the level of peritoneal reflection, it is considerable risk. Cervico-esophagogastric, again during esophagectomy, it's a high risk, whereas iliorectal has the lowest risk. So these are the definitive factors. Technical factors, you should have an adequate blood supply, less tension, right? And airtight, and the technical aspect, it should be an airtight and watertight anastomosis. Technical aspects. Moving on to location. Pancreatico-enteric, colorectal, right? All these have increased risk. And local factors, obvious infection is there, fluid collection surrounding the anastomotic site, will bowel related factors secondary to radiation, etc. Radiotherapy, all these can cause Crohn's disease, will have an increased risk of leak. Which of the following factor will impact the rate of anastomotic leak? Right? For that, you need to identify implicated factors: bowel preparation, usage of drains, right? Advanced malignancy, patient is in shock, receiving blood transfusion, right? Smoking, patient on steroids. All these can cause anastomotic leak. With regard to staplers, forceful extraction, tears, failure of the stapler to fire or close, all these impact the risk. So let's answer this question. Which of the following will impact the rate of anastomotic leak? That means The factor can be either preventive or aggravating the risk of anastomotic leak. Use of pelvic drains, it is of debatable because some studies will tell that it has decreased the rate of anastomotic leak by removing the fluid collection in and around the bowel and decreasing the septic complication. In some cases, it is introducing the infection and it is causing eroding the bowel, causing anastomotic leak. So either way, it has an impact. That is true. Alteration of microbial flora, increase in Enterococcus fecalis has seen to have an increased rate of anastomotic leak. So if you give a mechanical bowel preparation with antimicrobial prophylaxis, the anastomotic leak rate has decreased. That is an impact. Mechanical bowel preparation and oral antibiotics have an impact. Proximal diversion stoma will not impact the rate. It can decrease the consequences of anastomotic leak, or it can be a treatment for anastomotic leak, but it does not prevent the anastomotic leak. So that is it does not impact the anastomotic leak. The following statement regarding the intestinal fistula is false. Intestinal fistula, easy fistula. Iatrogenic is the most common cause of acquired GI fistula. It's a true statement. Long tract more than 2 centimeters is considered unfavorable for spontaneous fistula. Generally, longer tracts will close spontaneously. That is a false statement. Recurrent ECF is seen in 10 to 20% true. Surgery used after, usually done after 6 to 8 weeks, because for all the inflammation to settle and to inflammation reaction to settle, so that it will be easy for us to gain entry into the abdomen later, in a later period. These are the favorable factors and unfavorable factors. Longer tract, single tract, and when it is from a jejunum, colon, or a duodenal stump and pancreaticobiliary, no adjacent large abscess, no intestinal disease, no distal small bowel obstruction, bowel abdominal wall is not diseased, patient is not malnourished, no sepsis. In such cases, favorable for closure. When these are not there, sepsis is there, patient is malnourished, mesh is there, distal obstruction is there, intrinsic intestinal disease is there, infection is there from the duodenum, stomach, or ileum where the output is high. If it is an N fistula and multiple tract and short tract, these are unfavorable factors for healing of intracutaneous fistula. So with this, we have come to the conclusion of postoperative care and the postoperative complications. Now let's discuss about other aspects. What is a day surgery? Day surgery is nothing but surgery requiring a 23-hour stay, right? Surgeries, admission for surgery and discharge on the same day, wherein you do all anesthesia and the OT facility. Surgery is limited to less than 1 hour, and now in the recent belly, it includes even up to 3 to 4 hours can be considered for daily day surgery. Not if it is including a overnight stay, it's not day surgery. What are the benefits of undergoing a day surgery? Number one, more inpatient beds are available for patients in need. Recovery can occur in the comfort of the patient. There is less disruption to the domestic situation and reduced risk of hospital acquired infections. What is the criteria for day surgery? These are the enlisted criteria. You have a surgeon factor, medical factor, and a social parameter. Surgical factors include the surgery should have a low risk of postoperative bleeding or complication. After surgery, the patient should be able to eat and drink normally. Less postoperative pain, if at all happens, it should be maintained by oral tablets. Patient should be available for ambulation postoperatively. If these 4 things are satisfied in a surgery, that surgery can be considered for a daycare. With regard to medical, the patient should have a ASA grade 1 and 2 fit, non-obese, diabetic, if should be under control, well-controlled epileptic patient. Social factors, patient should live within 1 hour drive to a hospital with an accompanying by a responsible adult. And you have a proper phone service. Right. Can I answer this question? Which of the following is not a criterion for selection into day surgery? You have a surgical complexities, you have comorbidities, support system, but not the age. Age is not the limiting criterion for a day surgery. Which is false regarding day surgery? Surgical procedures that last less than an hour are included. Yes, that is true. Now, even up to 3 to 4 hours also included. That is true statement. Patient with uncontrolled diabetes are not considered suitable for day case. Yes, can be diabetic but should be controlled. That is a true statement. Preoperative assessment should follow the same principles as for any other patient and should be nurse-led. That is also a true statement. Surgeries that require 23-hour stay, including overnight stay, is classed as day surgery. That is a false statement. There should not be overnight stay. If at all the stay is happening, it is not a day surgery. Admission and discharge should happen within a day. Which of the following patients should be posted early in a day surgery list? A 65 female with no comorbids planned for knee replacement. 48 male with no history of cholecystitis planned for lap chole. 14 female planned for tonsillectomy. 48 male scheduled for ureteroscopic removal of calculus. So while planning a day surgery list, you should always post surgeries for patients whose recovery will be delayed and for surgeries who will require a delayed postoperative period. So surgeries with long recovery times include knee replacement, tonsillectomy, hip replacement, and a complex lap chole. Patients who require longer recovery time include very elderly and BMI. So in this list, it is an elderly patient and a high risk surgery. So this is a surgery. This case should be posted early in a day surgery list. So here elderly will have a longer recovery time and knee replacement will require a longer recovery time. Next should be tonsillectomy. Third one should be this one, and fourth one should be this ureteroscopic removal of calculus. Right. Now finally coming on to medical errors. Do you know that medical error is the third leading cause of death? What is the medical error? From Schwartz, it is defined as an unintended act, either of commission or omission, or an error of execution or an error of planning, or any deviation from a normal process of care. That is a medical error. These are the various medical errors that is enlisted. Adverse event is nothing but an injury caused by the medical management rather than the condition, rather than the disease per se, right? Where it can even prolong the patient hospitalization, prolong the cause of disability, or even cause death of the patient. That is an adverse event. Negligence is nothing but you are giving a care that is below the standard care. Near miss, error that does not result in a patient harm. That means error has not reached the patient. Right. Sentinel event is unexpected occurrence involving the death or serious physiological or psychological injury. So this requires immediate investigation and response. Common examples include transfusion reaction related issues, wrong side surgery or wrong surgery, medication error, or leaving a foreign body like a gossypioma or a metal object. Like sentinel events are called never events. They should never occur. So this is a tablet column from Bailey showing the patient safety incidents. An adverse events is defined as an incident that results in harm to the patient, right? Whereas a near miss injury is nothing but an incident that can harm the patient, but that does not reach the patient either by chance or by a intervention. Whereas a no harm event is nothing but an incident has happened and it has reached the patient, but no harm has happened either due to chance. So, which of the following is not a patient safety incident? Near miss is a patient safety incident. No harm event, adverse event is a patient safety incident. And never event is not a patient safety incident. A near miss event is defined as near miss is nothing but incident has happened, it has not reached the patient, so it has not caused harm. So, incident that result in harm to the patient is an adverse event. This is a false statement. A harmful event is prevented from reaching the patient is a near miss event, right? A harmful event reaches up to the patient but does not harm. That means it is a no harm event. So, this is a false statement. Factors that contribute to patient safety incidents include all of the above. These are the following factors that contribute to patient safety incidents. We have human factors, system failures, and medical complexity. Human factors, inadequate patient assessment, delay in the diagnosis or error in the diagnosis, not performing adequate investigational tests, error in doing the surgery, or inadequate monitoring, or deficiency in training or expertise, fatigue, overwork, right? Any drug abuse, all these are human factors. System failures is poor communication, inadequate staffing, infrastructural inadequacy, then lack of coordination at handovers, drug similarities can happen, and equipment failure, lack of parts or skilled operators, all these can be a system failure. Medical complexity, you have advanced and new technologies, certain potent drugs, the side effects and interaction are not generally analyzed in the real world scenario. In such cases, these are the factors that can cause patient safety incidents. Which is most important for healthcare facility providers from the three components of Heinrich safety pyramid? A Heinrich safety pyramid is nothing but all are equally important. What is Heinrich pyramid? It is nothing but an error model, right? It identifies, it states that for every major injury, we are missing 29 minor injuries and 300 near misses. So one major injury in system, it masks many minor and near misses. It also also proven by Pearson Swiss cheese model. Like these are the error pathways. If it is not being stopped at any level, it leads up to an adverse event. If it is identified and either it is stopped either due to chance or by likely intervention, it can be a near miss. Right? So we need to avoid all those factors that are responsible, like have a proper system. The human factor should be normal. Everything should be normal to avoid the patient safety incidents in the hospital. Okay. Moving on to the last component, you have a WHO surgical safety checklist. In WHO surgical safety checklist, at the time of induction, you sign in. And before skin incision, you take a time out. And then after surgery, that is called sign out. So during a timeout, that means before surgical incision, what all you will do? You check for antibiotic prophylaxis, that is true. Site marking, sign in. Instrument count, sign out. Any risk of excess blood loss, that is also during signing. So this is the answer. This is the surgical safety checklist. During a timeout, you ask for antibiotic prophylaxis being given within the last 16 minutes. So with this, we have come to the end of the class, and these are the few important tabular columns that picked up from Schwartz for your references. What are never events? Surgery performed on the wrong part of the body, wrong patient, or a wrong procedure done on the patient, or you unintendedly places a foreign body, or a death of a class A1 patient due to surgical complication. These are never events. What are the risk factors for retained surgical sponges? Most commonly seen with emergency surgery, where proper counting won't be done, unplanned changes in the procedures, higher body mass index, where you might lose, or in surgeries where bleeding is there, you might lose the soaked pad. Multiple surgeons, like change of surgeons between the operations, can also be a cause for retained sponges. Multiple procedures, you are accessing 2 or 3 quadrants in the 2 or 3 regions in the same patient, counting can miss. Involvement of multiple operating room nurses or staff members, because handing over won't be that much adequate. That might lead to improper counting or wrong count. Case duration covering multiple nursing shifts, like you are doing a surgery for more than 12 hours, like 2 shifts of nurse are changing. In such cases, retained surgical sponges can happen. With this, we have come to the end of the discussion. So I think I have completed all about general surgery aspects as well. If there are any questions, we have some 5 minutes for question discussion. If not, we will wind up the session. I wish you all the very best for your upcoming examinations. With regard to the first question, you have a drug-eluting stent planned for elective chole, can be done after how many months, sir? 6 months or 1 year? Elective chole, you have to wait till 1 year, right? At least 6 months should be there. Okay. So the answer will be, according to Subiston, 6 months will be the best answer. Because it's kind of a quasi-emergency. It's kind of a quasi-emergency, we cannot prolong it. What is the concept of NNT and NNH? Concept of NNT is how well the study outcomes can be applied in real life scenario. Supposing I gave an example, giving the chemotherapy, adding cetuximab in head and neck patients have an absolute survival benefit of 6%. So to achieve a absolute benefit of 6%, how many patients you have to treat? That is numbers needed to treat. If the numbers needed to treat is less, that means adding the drug definitely has the advantage, as the drug is more efficacious. And the numbers needed to harm, every drug has the side effects also. When the numbers needed to harm is very high, that means after 100 patients you might have face a harm. That means the drug is all the more safer. And numbers needed to treat is less, numbers needed to harm is more. That means the drug is more efficacious and more safer to achieve the outcome that has been obtained from the randomized study. Gunshot wound through and through, injury to the colon, management, sir, primary resection anastomosis or ostomy. It depends on the site of the colon and the grade of the colonic injury, right? And also the physiological status of the patient. If the physiological status of the patient, just hold on a second. If the patient is physiologically stable, in such cases, you can do a primary resection and anastomosis, but generally, left colon, it's always preferred to go for an ostomy. So if the colon causing massive fecal peritonitis, physiologically unstable due to blood loss and etc., in such cases, ostomy will be the treatment management. It is a damage control surgery. Right? Thank you very much, students. The formula is an extra edge for you, right? You can read that formula for numbers needed to treat and numbers needed to harm, right? You can, that's an extra edge for you. I'm just giving an overview so that it will be very easy for you to choose the option even if you don't know completely about it. Yes. Thank you very much. Thank you, RRM management, for this opportunity. I think we can close the session. Thank you.